Welcome to the Fight Cancer with Dr. Prasad podcast, your source for the latest, most reliable, and research based information about cancers and their treatments. Hello, I'm your host, Dr. Prasad Dandekar. I'm an oncologist and I head the Radiation Oncology Department in Sir H.N. Reliance Foundation Hospital in Mumbai. When I was doing my MBBS in late 90s, I very distinctly remember one patient coming to us with a CT scanner. And when I saw the CT scan films, it was like magic. The CT scans that we were used to seeing those days were those gray dots and white images of bones. And then there was this patient who had a CT scan which had three-dimensional images of the body in both, as if you had cut the body horizontally, vertically, in different angles. And that was magical. And that is when I heard the name of our first, the doctor who started that clinic, Dr. Bhavin Jankharia. Today we have Dr. Bhavin Jankharia with us, and it's a pleasure to have you, Dr. Jankharia.
It's my
You are the
pleasure.
man who revolutionized imaging for patients in Mumbai and probably in India, and we are very glad to have you over to discuss with us what are the different options for doing scans for our patients. Dr. Jankaria is also a writer and an educator. He's very avid. He is very active in teaching students. So he's a very interesting, well-rounded personality, and I'm sure we are going to have a interesting conversation today.
But thanks for having me here. I mean, I think that's entirely my pleasure.
So one of the common questions, Dr. Jankaria, I get in the clinic is, Doctor, why are you asking so many scans? We just got a sonography done. Now you want us a CT scan, then you would want us an MRI to be done. And patients have so many questions as to, in their mind, it's like, okay, you want to see what is inside me, why there are so many different types of scans that you want to do. I'm sometimes at loss as to how do I answer that question. How do you explain to your patients?
So, being a radiologist, that means I'm a service provider to people like you. Most of the times, I don't have to answer that question. I just have to do the scan. But coming back to your point, and I think patients do ask us, why are we repeatedly coming back to you for, an ultrasound and an MR and a PET? So let's take an example of a patient who we saw today. The patient has a uterine mass, but the patient presented with breathlessness. So when they did the chest X-ray, which is the first radiology investigation that was done, they found spots in the lungs, which were worrisome. Now, given the age of the patient, they directly went ahead with a PET CT, which is a modality that allows us to see the whole body and abnormal areas light up. And the spots in the lungs appeared to be spread from a cancer. But the cancer appears to be in the uterus. So the uterus is in the pelvis. And while we know that there is something abnormal in the uterus, PET is not the modality that allows us to see whether it is superficial inside the uterus or it's spread into the muscle or it's gone out of the muscle. So then we've done an MRI for the same patient today to see what is happening with the uterus and what would be the best way to get a biopsy done. Perhaps at some stage an ultrasound may be required because ultrasound shows the ovaries better than any other modality. So depending on the question to be answered, different modalities show different things. And I think the classic example is of a gallstone, that the gallstone is best seen with ultrasound, which may be the cheapest test possible, but at the same time may be seen with MRI and with CT scan as well. And sometimes you'll end up doing all three depending on what is the information required. So that's how it is.
Yeah, and I find it very interesting when patients say, "But doctor, we have just done a PET scan, and now you want us to do a sonography because sonography is like way down in the pecking order of the images, but we know that the lymph nodes are best seen on sonography." Now, 1895 was the year when X-rays were discovered, and for a long time, X-rays remained the mainstay of imaging because we really didn't have anything. So, how did we evolve from X-rays to where we are currently?
So the evolution's been quite rapid. So 1896 was the first X-ray machine. 1895 was when X-rays were discovered. From then till about 1971, and you'd say that's almost 90 years, there were only X-rays in all forms. So you had tomography, you had procedures like barium studies, etc. And then 71 was when we had the first CT scanner that was introduced. And while it took 20 minutes to do one section, in 20 minutes today you'd finish two scans completely. It revolutionized things. You could finally see the brain. And that had been a black box till now. And then because that needed computing power. See, X-rays were entirely analog. You had a machine, you had a film, you had all kinds of chemicals to be used. But for the first time, images were produced using computers, using zeros and ones. And then that opened up the possibility that you could marry computers and imaging technologies and create things that were earlier not possible. And as computing power improved, the ability to create images from different modalities improved. So then from CT, we landed up with MRI, and the first MRI in Mumbai was in 87, in India was in 86, but 5 years prior to that in the world. You had ultrasound, which came in the 70s, and then has also improved a lot from additional computing power. PET CT happened because you married nuclear medicine with X-ray technology. And then from 75, 79 onwards, we're looking at about 50 years. The next 50 years have seen an explosion of technologies that have completely changed the way we practice medicine. It's not just radiology. How we practice medicine has completely evolved depending upon the modalities available. For example, you would have never dreamt that a pregnant woman would require 3 ultrasounds to be done during the course of the pregnancy. I mean, earlier, and even when I was a resident, there was hardly any ultrasound being done. It wasn't there in the late 80s. And, today it's changed the way obstetricians practice obstetrics or gynecologists practice gynecology. Having said that, everything's plateaued now. So we don't really have any new paradigm shifting modalities on the horizon. So we're just improving on things that are already there, but complete change. I mean, X-ray for 90 years and then the last 50 years, tons of other stuff.
Yeah, that's been the journey. And just for our viewers, CT scan actually is a computerized tomography scan. So that's where the computing power came in. And one of the concerns that our patients have is CT scans have X-rays, and X-rays are not really good. I mean, I'm a radiation oncologist, and patients are obviously worried about radiation. So the how how often can they do CT scans? Are there any concerns regarding CT scans?
That opens up a whole can of worms, doesn't it, Prasad? So,
Yes.
um, radiation in the doses that are used by you when you're treating cancers, right? You're treating cancers to kill the cancer, so the radiation dose is that high. That's not the dose that is used in diagnosis. In diagnosis, the doses are between 1 to 10 millisieverts. I'm just throwing a term out there, just because I'll come back to that. Um, and in reality, even 127, 28 years after the discovery of X-rays, we have no proof, or we have nothing that tells us that diagnostic radiation causes cancer. That's the worry that everybody has, but we have nothing. What we have is a mathematical construct where data from Hiroshima, Nagasaki, and Fukushima has been extrapolated to say that if you receive, atomic bomb, let's say you receive 1,000 millisieverts of radiation and X number of cancers are created, then at 1 millisievert, the chance of you getting cancer is 1 divided by 1,000, something like that, which means that it continues that at whatever level of radiation there is a risk of cancer. And it has never been proven. There's no longitudinal study that shows that. There is no physics that explains that that is okay, because all of us have background radiation anyway that we're exposed to. So in theory, you could do a CT scan every week, right? Because each event is a stochastic event of its own. But obviously, we don't want to do that. There are lots of other issues as well, logistics apart. Um, and so, if you have to do a CT scan once every 3 months or 6 months because you have a particular cancer that requires that kind of treatment, you should just do it without even batting an eyelid. There is absolutely no reason to bother about that. Theoretically, for argument's sake, if you say that, okay, I strongly believe radiation causes cancer, then that cancer occurs 20 years later, if at all. So you still are looking at 20 years, and the risk of that cancer happening perhaps in the future cannot determine your decision making today if you require that test. So unnecessary testing, obviously we don't want to do because there are other issues including cost, etc. But necessary testing, there is absolutely no harm from the radiation, from CT scans, PET CTs, X-rays, etc.
Yeah. So judicious use of technology will give us the optimal answer as to what
Yes.
is wrong rather than and avoid causing damage to the patient.
I mean, there's nothing worse, and we've seen that sometimes with helicopter parents. There's nothing worse than not doing the study, which then leads to worse outcomes. We've seen that with appendicitis, where a CT scan was required. Parents refused, they wanted an MRI, which is not the right modality. And by the time all this got sorted out, the appendix had burst. The child survived, but there was a very stormy period, all of which could have been avoided. And this is not just one example. You keep getting these. So there is no question that when a test is required, it just needs to be done. That's it.
Yeah. So I see a lot of head and neck cancers, and that those are the cancers of India. And there CT scan plays a big role because on the CT scan, you are able to see bones much better than you are able to see them on MRI. And in head and neck cancers, the staging of the disease is also dependent on is the bone involved, is the bone not involved. And I think CT plays a very vital role in deciding the treatment also, because if the bone is not involved, in some patients of laryngeal cancers, we would do just chemotherapy with radiation. And if the bone is involved, we would actually send across the patient to surgeon for surgery. So the outcomes also vary. CT scan is absolutely vital in that. But I think another important role that CT scan has now taken over is on the biopsy front. Earlier, we were dependent on only the surgeons actually looking at the tumor, taking a chunk out of it, and the pathologist examining it, which was very difficult because not all tumors can be reached by surgeons, and sometimes that means that you have to cut open the patient. But now, and you are really the one of the best persons to do a biopsy, you are fantastic at it. How do you see this role of CT scan guided biopsies evolving?
So I guess it started again all the way back in 87. So from the time that actually CTs have been around, radiologists have been finding out ways to use the whole technology better. And it's when you have to get tissue out, as you said earlier, the surgeons would operate and remove that tissue. Today, when you can see the abnormality on CT or ultrasound for that matter, depending on the organ, you can actually guide the needle into that organ extremely precisely. Now, we have something called CT fluoroscopy, which allows us even more almost real-time manipulation of the needle. And with that, therefore, without the patient having to go through major surgery, we can get samples out, send them for testing. In our country, TB is endemic, so the first thing you do is check whether the person has TB or tumor, and then if there is tumor, the subtype of tumor, etc. Now, this is actually increasing because as diseases and their treatments evolve, let's take lung cancer for example. 15 years ago, our only job was to biopsy and say, is there cancer? And the pathologist would say, is there cancer? Is there TB? Is there something else? Today, the oncologist sends us a patient and says, we need material for EGFR, ALK, PDL1, ROS1. So these are all different markers that help decide which chemotherapy drug will help. And then in the end, just take extra material. We'll keep it for NGS, which is next generation sequencing in the future. And our trade-off is there is a limit to the number of tissues we can get out from a patient um, uh, safely, because there is a safety issue. You put a needle inside, patients can bleed in the lungs, they can have an air leak. So we're cognizant of that fact. And so we keep having to balance, safety versus the amount of tissue that we have to remove. But over the years, this entire process of getting biopsies is just exponentially increasing because more and more now people accept the fact that we just need to prove the diagnosis before we start treating, even with tuberculosis. The age of empirical treatment is kind of getting over.
Yeah. From empirical, we have moved to precision medicine, which is where all these biopsies come in. And in fact, what I'm seeing in my clinical practice now is that you, of course, do biopsy at the beginning and you prove that there is cancer, what type of cancer. We do all sorts of these tests, which you mentioned. But even when we treat the patient, and sometimes the patient has a relapse, and in some patients, we have a condition called as an oligoprogression, where suppose if the patient had multiple sites of cancer, we are giving systemic therapy, the chemotherapy or immunotherapy, and the cancer has regressed. But at some one place, the cancer seems to be growing. Then we want again a biopsy from there to prove if that cancer is the same cancer as the earlier or different. So in every patient also, I think we are doing biopsies on multiple occasions, not
Yes.
just one occasion, and that has been really helpful to
It's
to
funny. The first time a person has to go through a biopsy, they're extremely stressed. And when I counsel them, I tell them that. I said, for me, it's an everyday thing. For you, it's the first time in your life, and so you have to de-stress them. But if they have to go through it the second time, the third time, it's such a different experience because now they've gone through it. They are aware of the possible complications and they're much more at ease. So there is that thing that if you've done it once, you kind of know what's happening, and it makes the next biopsy easier and easier to do from a patient perspective.
Yeah. And of course, the pathologist role is very vital. We are going to have another session with the pathologist as to, you have done an excellent job of taking the biopsy, but then what do we make of it? So that's a pathologist job. Now, CT scans are that way relatively easy to do. I mean, I have recently had my CT angio done for, just to check things. And it was like, before I knew it was done, like fraction of a second, I'm like, okay, done. And but MRI is another animal. I mean, I had my MRI. I was having severe migraine a few years earlier, and I had my MRI, and I almost had a panic attack just getting into the machine. And then since then, I've had a couple of MRIs, and now I've gotten better at it. But it's such a different experience from CT to MR in terms of how the patient feels and perceives it, and also what sort of information that you get. So, do you want to enlighten us about that?
The two completely different modalities. I mean, CT uses X-rays that go through your body. MR uses magnets which are outside the body that look at perturbations within the protons in your body and create images from there. Um, Unlike CT, which is a single thing that we do, at the most we give a dye or contrast and we repeat the scan with and without. With MR, we have manipulation of tissues that occur based on multiple parameters. And so each MRI that we do has different planes and different sequences. So, just for example, if you're doing a knee, you have a sagittal, a coronal, an axial, within which you have a, a PD, proton density fat sat, a T1. I'm just taking those terms out to say that there are different sequences that manipulate the tissues and they look differently. And because of that, each MRI takes time. Today, I can do a CT scan of the lungs in about a second, 2 seconds at the most. So, in and out time would be 5 minutes, 10 minutes. In an MRI, it would take still a minimum of 20 minutes just to do a basic knee. But if it's a brain with a tumor protocol where we also add things like spectroscopy and perfusion imaging, sometimes a functional MR, uh, everything takes time. A tumor protocol would take 40-45 minutes. You add functional, that's an hour, another hour straight in, etc. So it all depends upon the question to be answered and the sequences and the protocol we use for that. So it is a completely different animal, as you rightly said. They're just different modalities. Yeah.
So CT scan to me sounds like more of a simple sort of if you're taking a simple photograph or a very basic video, and MRI is where you have a really fancy digital camera, almost the cinematographic camera, where you're going to shoot from different angles, you're going to change the color palette, you're going to create different textures. And when you combine all of this, you actually get a very detailed and a complete picture of what is happening in this patient's body.
But to take that analogy further, it's like somebody with an iPhone 16, let's say, with the three camera setup, versus, as you said, something very complex. The detail in the images is still the same. So a CT is still an extremely precise image with very high spatial resolution, as is the MR. But it's the look of the image that changes. So you get a more lush, let's say, video when it's created by a professional versus an amateur. But still, if the person who's seeing the image knows what they're looking for, then it doesn't matter, because you just need to be looking at that again based on the organ and the indication. So yeah,
Yeah.
that was a nice analogy.
Now, I was sort of reconstructing it by
Yeah,
because
yeah.
as a clinician, when I see the MRI images, so CT is so very simple because
Yes.
you know the basic anatomy. You're looking at it. It's almost like I'm cutting open the patient and seeing it scan. MRI is like really difficult for us to understand because T1, T2 images we can understand because they are very, very similar to CT scan images. But when you talk about diffusion weighted and perfusion, it becomes very complex for a non-radiologist to understand. So there we really need to talk to the radiologist and say, okay, this is the image, but what is it?
What does it mean? But that's why we've done it as well, so that you're still dependent on us. It's it's a whole conspiracy.
No, it's always a pleasure for us to, we walk across the floor and talk to our radiology colleagues and get more information from them because that is how we are able to deliver the best of
Yes,
care to our patients, that,
true.
all the best of the minds are coming together. One of the thing which is fascinating about MRI is the MRI brain, where we have gone to a completely different level of details now. Earlier, we were focusing on okay, there is brain, there are different parts of brain, and maybe there is a tumor. Now you are able to tell us far more details about the tracks and everything. So how has that changed?
No, so these are incremental changes. Like I said, the paradigm shift was when you could see the brain first with CT. MR didn't create a paradigm shift for the brain. I mean, it showed things better, but the paradigm shift with MR was the spinal cord because you could never see it with CT. You finally had something that showed you the cord and the nerves. That changed spine. The whole discipline of spine medicine uh, is has been completely changed because of one modality, and that's MR. Everything after that has been incremental. So every couple of years, you have one new sequence, one new method. So tractography, which is a diffusion-based technique that allows us to see the tracks, is a nice technique. It gives additional information. It adds to the value of the MRI. Functional MR, similar. It adds, gives additional information. But the basic image uh, remains the same. You still need your basic core axial coronal sagittal, and then you have add-ons depending upon the question to be answered. So yes, every couple of years we have something new. These days we're working with a sequence in MR that we do in the bones, which creates CT scan like pictures. So you don't have to do a CT scan, or if a person has forgotten to do an X-ray, then this helps us with that. But it's not mandatory. I mean, without that, we'll still get to a diagnosis. It's a nice to have, but it doesn't change, the basic MRI outcome. Let's put it that way.
Yeah. And clinically, I think it will gradually make a change. Even the tactography, the surgeons are also more aware when they're
Yes.
operating that, how far can they go to remove
Yes.
the tumor? That really helps. Even in radiation, it helps us to a certain extent that, okay, how much dose can I give to this area? Um, First time radiation may not be so much, but especially when we are doing re-radiation or
Yes.
second time radiation, when patient had a tumor, we operated, gave radiation, and the tumor has come back, and we want to do radiation again. That time, I think this information is critical because we
Yes.
don't want to damage a particular part of the brain, which is especially critical in that area. And you mentioned spinal cord. That has been a game changer, as you said, because earlier we were dependent on very invasive procedures like, spinal tap to check if there are tumor cells. Nowadays, if we have brain tumors which have we know propensity to spread to spine, we simply ask for an MRI spine, and it gives such beautiful details. In fact, far more details than the CSF cytology can give. So that has been a big help to all of us. Uh, what is happening in terms of the noise? I mean, the MRI, one of the major problem for the patients is the noise that MRI creates. Is there anything we can do for that?
So it is, I mean, it's again an ongoing process. We have some very good headphones that help. We have music with the headphones. And again, every year it gets better and better. It's never going to be completely noise free. But I think we're down to almost 20, 30 decibels, or rather, let's say about 50 decibels less than it used to be, let's say 5 years ago. So every couple of years is it improves.
Yeah. No, I remember the first MRI I had, which was like probably 10, 15 years ago, and the
Yeah,
recent MRI I
was
had,
bad.
very different, very different. This time, in fact, I actually went to sleep.
Yeah,
The noise was so repetitive. It was
yeah,
like, okay,
yeah,
it really
yeah.
induced me to sleep. I didn't have any music on because they didn't have that sort of music that I like. And I said, I don't want to listen to the music that I don't like. So I said, okay, I'll just relax. And I literally went off to sleep, which was fantastic.
So we now, I think this time when we upgraded, we have this thing where we can take the patient's phone and connect it with Bluetooth to our sound system, and we can play the patient's music preference as well. So these are all things that keep getting added on, that's there. But since we are on this topic, and this just came to my mind, the paradigm shifts that occur are not just based on the modalities, it's even based on disease diagnosis. And we have this classic example of a disease called multiple sclerosis, which till about 1987 used to be considered non-existent in India. It was only said to occur in Parsis, in some people who lived abroad for a long period of time, or foreigners who were here in India. And I remember a lecturer in Sion Hospital where I studied who presented a classic MS case in 85, 86 and was told that, if you present like this, you will never pass your MD or you'll never do well in life. He'd finished his MD, he was a lecturer, and was castigated by a visiting neurologist. 87, the first MRI came to Breach Candy Hospital in Mumbai, and suddenly people were seeing classic textbook pictures of multiple sclerosis on the MRI images. And within a year, we had an epidemic of MS. Now, the MRI didn't cause the MS. You could have that correlation as well. But it was clear that we as a nation had deluded ourselves into believing that MS doesn't exist in India, except in Parsis. And suddenly we realized how wrong we were. Nobody went on record to say we're sorry we were wrong. But suddenly we found that we have multiple sclerosis as much as anywhere else in the world. And that was it. It took about a year or 2 years. It diffused through the community, and suddenly MS was as natural and normal as you could be. So, a single modality that suddenly brought about a disease that people believed didn't exist. So, things like that. And these things keep happening. Same thing with pulmonary thromboembolism, and there are other examples as well.
But even in oncology, I think MRI has changed things because now with MRI, we are able to detect even the tiniest of the tiny brain metastasis. So
Yes.
if I have a patient of breast cancer, lung cancer, prostate cancer, whatever, and if they're advanced stage, suppose if it's a lung cancer which is advanced stage, we would do an MRI brain upfront to check if
Yes.
it has spread. Earlier, we didn't have that facility, so the patients would present to us with very large brain metastases which are symptomatic. Now, we are able to detect, I mean, I do radiosurgery for these patients, and we are seeing tumors which are like zero point 0.4, zero point 0.5 centimeter
Yes.
size. And the beauty of it is you are able to treat that, and hence you're preventing damage to the surrounding brain tissue. So these patients are able to survive for a very long time without any brain side effects of radiation because we are detecting the tumors early on. And now I have so many patients where we did radiosurgery. Patient was continued on systemic therapy, chemotherapy, or immunotherapy. Then they had maybe one more lesion in the brain, one more lesion here and there, and we keep treating that, and they have otherwise a very normal lifespan without any problems. So MRI has really helped us in that terms. Even in prostate cancer, for example, I mean, you we can't see prostate on anything else but MRI. So when I do prostate cancer radiotherapy, MRI has to be done. And then the patient's question is, Doc, you asked us to do a PSMA PET scan. Now you asked me to do a biopsy on sonography. And now you want me to do MRI. What's happening here? But that is what we need because we need to see the whole picture of how things are inside your body.
And I sometimes think maybe we should just have a lot more written material that explains why we're doing what we're doing and for what. And I think, I mean, you take with prostate biopsy, since you mentioned that we've been traditionally doing transrectal ultrasound guided biopsies, and now when suddenly you could fuse the MRI and the sonography images because of better computational power and in real time guide needles in using those fused images, now you can do transperineal um, biopsies, ultrasound guided, but you don't go through the rectum. So you reduce the chance of infection. But none of that would be possible unless you fuse the MRI and the ultrasound images. So you do need the MRI before you go ahead and do a transperineal biopsy. So each of these has nuances that, are become um, sometimes very difficult for a lay person, sometimes very difficult for doctors who are not part of that specialty to understand. And even what we do depends so much on what are the possible treatment options. So, if in the past I had the ability to pick up a zero point 0.5 millimeter metastatic lesion, what would you do with it? If you didn't have options, what is the point of me even doing those tests to pick those up? Today, when you can treat them, suddenly all of that becomes relevant. So it all goes hand in hand. Just because I can show something doesn't really mean it's great unless you know what to do with it. And I think sometimes people forget that in their enthusiasm to get tests done. And the point is, if you're not going to be able to follow up on the results of the test, then doing the test was pointless. So,
Many a times we have patients who are, in advanced stage of cancer, even metastatic, where we are not able to offer much treatment, or we have offered palliative radiation to allay their pain or bleeding. And at the end of the treatment, their question is, Doc, when should we do the scan? And when I tell them that maybe we should not do the scan, because even if you do the scan and I see that something has changed, we are not going to offer the treatment until the patient becomes symptomatic. So just wait. If the patient has symptoms, only then we will treat. And for many patients, it becomes very difficult to understand. Uh, and some of them then they'll end up doing multiple scans and sometimes even receive unnecessary treatments,
true.
because once you see it you can't unsee it, then you are
I
forced
was
to treat
about
it.
to say that you
Yeah,
can't unsee
yeah,
the results of your scan that are written in the report. So
yeah.
uh,
So but these are
it's
the anxieties patients have.
yeah, but it's not oncology only. So if you think about it, right? Let's say you're 60 years old, you've got pain in the knee. Maybe you stumbled a little and, but you're still able to walk. Today, everybody gets an MRI of the knee done, right? The MRI of the knee will be abnormal. It will show you some cartilage loss, some meniscal tear, and you can't unsee those findings, right? Because then you know that, oh, my knee is abnormal. But there is nothing to be done. What was the point of doing the MR just to find all of these things when there are no treatment options for a 60 plus person or a 50 plus person? The only treatment options are building your muscles and being more active so that you don't lose function, which you are supposed to do even before the MRI has been done anyway. So why did you do it? So there are a lot of orthopedic surgeons who will not advise the MR, but the patients are so unhappy that the MRI has not been advised that now the surgeons will advise the MR because they know that if they don't, they will lose the patient. Because the patients expect that every time they have a problem with the shoulder or the knee or a hip, they must get an MRI done. And the point is, even with friends and family, I'm unable to convince them. They have pain in the shoulder. I say, don't get an MRI done. At the most, we'll find a tear. What are you going to do about? No, no, no. But we want to know. And then you can't unsee. This got just triggered by that word. You can't unsee those findings. So,
Even
yeah.
my mother, she had knee problems. I took her to my colleague, Dr. Vaibhav Bagaria. He's a fantastic knee surgeon.
Yes.
He got an X-ray done. And looking at the X-ray, he said, "Okay, auntie, you will need knee replacement at some point in future."
Yeah.
She was very unhappy. She said, "Why is he not doing knee surgery now? And we should do an MRI." I said, "But what are you going to see on that MRI? He's telling you what he's telling you. That is not going to change with the MRI." But I think once you have fancy toys, everybody wants to use
Yeah.
them.
But the parent dynamic is even more different because then there, though, it's like, they'll tell their children, you're not doing anything for me. I'm suffering. What are you up to? So
You're not a
there
good
the over.
doctor. You're not a good doctor. You're not advising me MRI.
So there it's a different thing entirely. Yeah, but anyway, that's that.
Uh, the other thing that I wanted to check with you is about the PET scan. PET scan came to India, I think, a few years, whatever, a couple of decades ago. And every time we think about PET scan, there's something new happening, something new coming up. And PET scan has, as MRI has, but PET scan probably even more so, has completely changed the way we practice oncology. It has changed the way we look at patients. it has changed the way we treat them, and it has changed the outcomes also. Because earlier we didn't have PET scan, so we didn't know if the cancer has spread to the other parts of the body. So if a breast cancer patient came to me and we do surgery, radiation, chemotherapy for that, which is focused on the local area. But if she had a liver metastasis, that went completely unnoticed and untreated. But today, because of PET scan, we are able to target that also. So it has really changed the outcomes of the patients. What are the different types of PET scans that are available currently for our patients?
So the first one, which is still the most commonly used, is FDG PET, which FDG stands for fluorodeoxyglucose, where glucose is tagged to the fluorine radiated molecule and then goes into areas of the body that consume glucose. That I think started in India around 2004, 2005, first in Tata and All India Institute, and now that's your standard vanilla um, modality that is used 90 to 95% of the times. After that came the DOTA PET. DOTA is basically for neuroendocrine tumors, and it attaches to somatostatin receptors. So whenever we suspect a neuroendocrine tumor, then we do a DOTA. And then in patients who are known to have neuroendocrine tumors, then DOTA is the way that we would monitor their treatment. After that came the PSMA PET, which is specific to the prostate. It binds to the PSA receptors, and it's a game changer for prostate cancer. It makes a huge difference. And currently we have FAPI, which is a fibrinogen, fibroblast activate. I keep activation protein inhibitor, and that basically attaches to the FAP inhibitors, which looks at fibrosis specifically, but is also very useful in all the tumors that FDG PET is not very good at. So, signet cell tumors, mucinous adenocarcinomas, many of the renal cell carcinomas, etc. So, these are the four molecules we currently have. We also have F18. We also have a couple of molecules for the brain specifically, like a DOPA, which is used, but these are very uncommonly used. In research, you'll find every month there is a new molecule that gets published with some trial or the other, but most of these don't make it to clinical practice. The two molecules that we want in India, which we are the people who manufacture these are not bringing them, are the ones for Alzheimer's, the tau protein ones, but hopefully in the next couple of years we should get those. But that's essentially what we have with PET currently.
Yeah, so FDG PET is the one that we are commonly using, and
Yes.
as you mentioned, for the prostate cancer, PSMA PET scan has become a complete game changer because many times on the FDG PET, we are not able to see the cancer spread of the prostate cancer, but when we are doing the PSMA, it shows up very, very nicely. And also because we have a CT scan combined with it, it's a PET CT scan. It gives us far more structural details
Yes.
as well, and the PET scan shows up the cancer cells. One of the interesting thing when you're talking about FDG PET is how FDG gets absorbed by the tumor cells. I wonder if that is also the reason why most people think cancer likes sugar and cancer absorbs sugar and hence they should not eat sugar. And that's a myth which is so difficult to handle. I keep telling patients that we still do not have any data which proves that if you take excessive sugar, your cancer will grow. Excessive sugar is anyway bad. Nobody should consume it. But I have seen patients rapidly lose weight because they have gone on a complete sugar-free diet. So
Why
there's no
you saw
carbohydrate
that
going
whole
in.
viral thing by Sidhu for his wife,
Yeah.
the cricketer, it just went haywire. But then so many, especially the Tata Memorial guys, got their knickers in a twist and went on a rampage against him, which also didn't make sense. But people do
I
what they
actually
have
thought
to.
that was a fake letter which they had sent because
No,
the
no, no,
way
no, no. It was a real
then I
letter.
figured out it was not fake, but it almost seemed strange to respond to that sort of a video, but in a way, it's
That's what
good that they
they
did.
should not have responded. But I've been trying to think of the game changer, that single game changer that came with PET, and I think that's lymphoma management. Because that was the first tumor that people started looking at because you don't really need a CT. The initial PETs were without a CT. CT was only used to calibrate the PET. And that was when lymphoma management changed completely because, to do a mid cycle and then an end cycle and then figure out how to change the management based upon the PET findings. That was the first malignancy that was whose diagnosis and treatment were revolutionized by PET. So just was thinking about that. Yeah.
I remember in 2004, 2005, RMC was the one who got the PET
Yes.
first,
Yes.
and Dr. Nair was there, and I had my
Yes.
posting there, and that was the first time I saw PET scan. I was like, "Wow, this is
Oh yeah.
amazing." And that was also the first imaging that we had, which was functional. I think the
Yes.
major difference between all other imaging and PET scan is it is functional, which means CT and MRI is actually showing what is inside, and PET scan is showing how is it working. Because on PET and MRI, many a time on MRI and CT scan, many times we still see the tumor left behind after chemotherapy and radiation. And on the PET, it actually shows that the tumor is not active. It's probably just dead tissue or just a scar tissue, which is such an important information because earlier what was happening is patient say had chemotherapy radiation, and on the CT scan or an MRI it showed that there is still tumor there. They would undergo a surgery only to find out actually it was all dead tissue,
There.
and the
But
morbidity was so much more. Patients had
correct.
so many side effects. So with
But
PET
that
now we are able
was
to avoid
yeah,
it.
that was a classic thing with mediastinal lymphomas, like those large prevascular space masses.
Yeah, in the
You would
chest.
do
Yeah.
whatever, but those masses never go away completely, and you don't know. So the sea change, and I remember we got our first pet in 2008, and it was such a game changer that we saw this guy with a 10 centimeter mass which had become 6 after 2 cycles, but with zero activity. You were at Deville 1, and you're like, wow, so the mass is still there. It'll take its own time to shrink, but it's completely responded. So this is a responder metabolically, morphologically, then who cares? But before PET, you would just keep assuming that that damn thing was not responding. And then imagine the amount of chemo and then extra radiation and then perhaps surgery. These are those complete game changers.
Yeah.
It's so good.
Yeah, currently we use PET scan for almost every clinical
Everything.
decision that we take for deciding on what further treatment to advise to the patient. Even the chemo protocols, the radiation protocols, the dosages are very different on
Everything.
responders versus non-responders. So that's been very different. Um, I want to revisit a little bit our discussion on MRI. I forgot to ask you one question there. It's about which machine to have the MRI on because you have zero point 0.5 Tesla, you have 1.5, you have 3, and now patients are so much more aware. They ask us, doc, do you have a 3 Tesla machine? Only then we have to want to have an MRI with you. So, which one to choose?
So the higher the Tesla, the better is the temporal and spatial resolution. So as a rule, if you had the ability to get a scan done, you would do it on a 3 Tesla. But a low end 3 Tesla is not as good as, let's say, a high end 1.5. So what happens is that that's just the magnet strength. You also have the coils, the other bells and whistles, which can give you the information that you want. And so sometimes it's quite difficult because a very high end 1.5 Tesla can give you equally good images in many parts of the body. Also, many parts of the body don't require the resolution of a 3 Tesla. So if you're doing spine, for example, just for disc disease and degenerative disease, it doesn't matter whether you do it on a 1.5 or a 3. Whether you're doing a knee or a shoulder, it doesn't matter. If you're doing a wrist or a finger, it matters. If you're doing a TM joint, it matters. So the smaller the area, the better the information with a higher field strength magnet. Um, so it's very difficult for referring doctors and patients to figure out. So sometimes you just simplify and say that yes, 3 is better than 1.5, 1.5 is better than a zero point 0.5, and then you kind of figure out what is available to whom. Um, in this comes the whole argument of an open MRI, right? Which
I was going to
obviously
ask you that
people,
next, as in we also have an open MRI,
yes.
which we very rarely use. So,
So I still believe it's better to sedate and do an MR rather than use an open, because most open MRIs are zero point 0.3 or zero point 0.55, which doesn't give you the kind of resolution that you want. Now, in countries in the West which are reimbursed by insurance and a patient doesn't pay, it's fine to do whatever, because if it's not good, you can get it repeated and nobody pays except the insurance company. In a country like India, where almost everything is paid for by the person concerned, you can't keep repeating MRI. So you can't justify doing a zero point 0.3, zero point 0.5 Tesla MR and then say, oh, but I'm not happy doing it, because you're not going to get a refund. And then you go ahead and do an MR on a 3 Tesla. So the first MR itself has to be the best MR you can do. Um, there is this new 1.2 Tesla open MR that you're talking about, which is nice in principle, for again areas where it perhaps doesn't matter. But when you want to look for a zero point 0.4 millimeter metastatic lesion in the brain, that's not going to cut it at all. So then, if the patient is still claustrophobic, we have ways of reducing claustrophobia, but in the end, you just give a little sedation, get the person and do the scan and out. I mean, it's like taking a Restil or one of these drugs, going to sleep and then coming out of it. So it's still it's just better to do it that way.
yeah. And just for clarification for our viewers, a standard MRI, which is 1.5 or 3 Tesla MRI, is more like a tube, a large
Yes.
tube, but it's a tube that you go in.
Yes.
Your technician will guide you through that tube. While an open MRI is, as it says, it's an open MRI, but with a much poorer resolution.
But
So,
it's not open. It's just that the gantry is wider. So it's like people don't get claustrophobic in a CT scanner because it's not a long tube. It's a very short tube, and the gantry size is about 75 centimeters, 80. So it looks quite open. And most importantly, your head is out, which is what most people want when it's not a head scan. In MR, even if it's a pelvic scan, your head is still going to be inside. And so that is where, it is a challenge. You can increase the bore. Now, we have a 60 centimeter, many people will have a 70 centimeter bore. Some people have 80 centimeters. But the problem with all of those, again, is that the wider the bore, your image quality can sometimes go down in specific patients. So you have to weigh one against the other.
yeah. So another thing which is quite a buzz nowadays is artificial intelligence. Right now, at least in India, we are largely dependent on the skills of expert doctors such as you to report the scans. Um, Artificial intelligence is sort of threatening to change that. What's happening in radiology from the patient perspective? How is AI in radiology going to help our patients?
So patients, I think, believe that radiologists will be redundant in about 5 to 10 years, which people have been saying for the last 10 years anyway, and nothing has happened. But so AI, how do I put it? It's another computer tool. We've been working with computers ever since CT scan came on the market. You talked about that 3D CT image that you saw. That's manipulation. And we keep doing all these, uh, things that are bells and whistles and wows. And what AI does very well is single tasks. right? So if you have a chest X-ray, which is a flattened 2D image, and you ask it normal versus abnormal, it does a very good job of that. If you have a nodule in the lung whose measurement you want accurately done, it does it very well. If you wanted to measure bone density, if you wanted to measure the calcium score in your coronary arteries, it does it very well. All of these individual special tasks, and we use those AI tools to do that. You want to see whether there's a hematoma in the brain on a CT versus no hematoma. Yes, it does a very good job. But general reporting of a CT or an MR to give you a full, concise report of everything that is abnormal within that, I just don't see that happening. I cannot fathom a situation. Maybe it's my lack of imagination at what is going on. But I also think that, like with everything in this world, when a buzzword comes in and attracts a lot of private equity money and government funding, people jump on the bandwagon, and then it is a loop that self-sustains, which and everybody believes that it's a game changer. Everybody thinks it will replace this one, that one. But engineers who run these AI companies and who come up with AI tools are extremely unidimensional, right? Because engineering is 1 + 1 = 2, and they believe, therefore, that in medicine, every problem is a solution that can be solved via engineering concepts. And I can tell you right away that in medicine, there is no 1 + 1 = 2 ever. It can be 3, it can be 11, it can be 21, it can be 0. And the same situation, it changes. And I'll give you a simple example. Forget oncology. Let's just take a blood pressure measurement of a 140/80. How it plays out in a 20-year-old, a 50-year-old, a 70-year-old, a 90-year-old, a 70-year-old who has comorbidities, a 70-year-old who's active, it is so different. And all that needs judgment calls. And however much you may use ChatGPT with reasoning or Gemini with reasoning, that reasoning is based on information that does not replicate the situation that you see in front of you. So I think certain repetitive tasks will get taken over, which I'm more than happy for AI to do. If AI can measure things for me and I save 30 seconds each time, that's wonderful for you. If you can get brain tumor volumes done automatically, accurately each and every time, fantastic. It saves so much time. Or if it can do some planning more accurately, it gives you the time to think about the dosages and all of that better. I think great, we will use everything, but it's just another tool. It's just another tool that we use in practice. And I'll tell you how I use AI a lot is when I'm stuck for a diagnosis and I see, like the other day, we had this 1.5-year-old girl who's got osteolytic lesions all over the body, and I'm not sure what it is. I will ask ChatGPT with a prompt as to, tell me what are the lists of differentials. It gives me a list which earlier I would have to go through PubMed, through 5 articles. It summarizes that in 30 seconds, saves me so much more time. From that, I know what it is and what it isn't, and then I can give it more prompts based upon what the patient has, and then come to a set of differentials that my mind knows are possible or not, and then I know what to do next. It has been a great game changer when it comes to searching for information. And I think that's where its biggest role lies. And as doctors, that's what we should be doing a lot, using these tools to help us save time so that we can give more time to our patients.
Yeah, absolutely. And we have actually started doing that because in the clinic, when I need a quick information, like you mentioned, you put it in ChatGPT or Gemini, you get that concise information, and then you can expand and go into the details. In radiation, we have actually started using AI to do contouring, as you mentioned. So we now have a tool where we do a CT scan for radiation planning, upload that CT scan onto the service. It's a cloud-based service, And within a minute or two, we get all the contours done. Typically, I would take 2 hours to do that.
Yes.
And our planning is also now getting AI based, so it's become much faster. Earlier, we would take 2 to 3 days to plan. Now, a good plan will be ready in like 10, 15 minutes. So it's getting really,
And
really
and who
fast.
wants to do contouring?
Yeah, obviously. I mean, it's a very repetitive,
So,
boring job. So
so
I'm very happy. I'm able to spend more time with my patients face to face
exactly.
and talk to them about how they're feeling rather than looking at the scan and, drawing
True.
lines on the scans. So perfect. So this was a very interesting chat, Dr. Chankaria, and we walked through so many details of the CT scan, the MRI, and the PET scan, and I think our patients will find it very useful in terms of understanding what are their clinicians telling them. So thank you very much for sparing your time and
My
giving us
pleasure
all the
entirely.
knowledge and your experience. Thank you.
No, thank you, Prasad, and all the best for your series. I know you're doing many more of them. It's a wonderful initiative, and I hope the patients really benefit from this. And I hope when these links are out, I'll also share it with
Yeah,
people
of
so that
course.
they can benefit from these. Yeah.
Thank you for joining us today. I hope you find today's episode informative. Please feel free to ask your questions in the comment section and we'll get back to you with the correct information. Please do like and subscribe to the channel, but more importantly, share this information with people you care about. Join me in this fight against cancer.